Don't miss that!
Okay, welcome back to Don't Miss That Radiology podcast. This is episode 15. We'll be talking about abdominal anatomy pearls, continuing where we left off. You might be wondering, where was I? It's been a week since I did a podcast. I was in Sacramento, California at the U.S. Masters National Champs, and I watched Ted Lasso on the airplane. I'd never seen it before. I heard great things. A great show. Highly recommend it. And I was ranked 4th going into the finals for the 200 butterfly, and I won it. So that made me think of Ted Lasso. It was a lot of fun, and I've made a TikTok out of it if anyone wants to watch. But you guys probably want to do anatomy review. So let's review what we did last time. What two structures pass between the aorta and SMA? And that's going to be the left renal vein and the duodenum. What two organs does the lesser sac go between? That's going to be the stomach and the pancreas. We talked about why that's important for pancreatitis. So there's our lesser sac between the stomach and the pancreas. What two veins combine to form the portal vein? Well, I gave a Pittsburgh analogy with the 3 rivers, but it's going to be the SMV and the splenic vein forming the portal vein. And that will be hepatopedal flow going towards the liver. Sometimes you'll get, with portal hypertension, hepatofugal flow flowing back from the liver. Okay, so this brings us to a great point where we can start having fun. We are going to correlate peripancreatic anatomy on ultrasound and CT. I did a TikTok for this. This is one of my highest rated TikToks, basically just an unknown slide with the answers next to it. So we have the aorta, big red, SMA. We'll have 2 structures going between the aorta and SMA, the left renal vein, going to big blue there, which is the IVC. We have the splenic vein joining with the SMV to form the portal vein, which will go into the liver. And we have SMA there, SMV there. SMV should be the right of that. And in front of the splenic vein is the pancreas. We'll also have the common bile duct and the gastroduodenal artery. And in front of everything is the liver. So let's watch this CT correlation.
Okay, let's go over the abdominal anatomy on CT. Here's big red, here's big blue. Realize the aorta is left of midline, IVC is to the right of midline, and here's our portal vein going into the liver, made up of the splenic vein coming from right to left and joining the SMV. And note here is our SMA off the aorta, and the SMV is to the right. Which organ is right in front of the splenic vein? Well, that's going to be our pancreas. So lots of high yield anatomy here, correlate it with the ultrasound and go back and forth. Practice this on your own CTs. Again, here's our big red, there's the celiac, there's the SMA, SMV, SMA should be to the left of the SMV should be to the right. Let's do one last review. Aorta, SMA, 2 tubes go between the aorta and SMA. The first is the left renal vein. There you see left renal vein going into big blue. And the other will be the duodenum crossing the ligamentotrites. We'll trace the duodenum back into the stomach. So every case I check the duodenum, making sure it crosses the ligamentotrites. I check that SMA-SMV relationship, look at the pancreas right there, make sure there's not a pancreatic head neoplasm. This is very, very important anatomy.
So this is high yield anatomy. Go back and forth with this, practice the anatomy with ultrasound, with CT, get your own scans to look at and try to always make these relationships. So remember, the SMV should be to the right of the SMA. Why is that important? Well, if it's not, you can have malrotation. And we also talked about how the duodenum should cross between the aorta and SMA and go to the left of midline, with most of the jejunum and small bowel being to the left of midline. If the duodenum does not cross the midline and stays to the right of midline, you will have malrotation. All the small bowel is to the right of midline. So this may present day 1 of life with a newborn with bilious vomiting. That's always the diagnosis of exclusion malrotation. But sometimes, depending on those how tight the malrotation is, the lad bands, you can go. This was a 30-year-old we diagnosed incidentally on the CT scan, and just to confirm it, we did the fluoro study, and the contrast passed through no problem. Just realized the colon's going to be on the left side. They might have left-sided appendicitis, but otherwise this patient was asymptomatic. So why is that SMV-SMA relationship so important also? Well, with pancreatic cancer, it's a definite tumor tipping point. So you can check out my rad path videos, but I talk about tumor tipping points. That's what the surgeon wants to know. That's going to affect prognosis and resectability. So again, we have our aorta, SMA, SMV. Our pancreas is right here. The duodenum is on the outside. But if you can imagine, if you get a pancreatic head mass, it goes into the SMV, SMA. If it goes in the SMA, that's definitely non-resectable. If it goes in the SMV, it may be resectable, but it makes the Whipple procedure that much trickier. So that's why this anatomy is so important. And again, between the aorta SMA, we have the duodenum and the left renal vein. So speaking of the aorta and the vessels, let's go over them. Well, the celiac trunk is at T12, and know the vessels off the celiac trunk. SMA is at L1, and remember the duodenum and left renal vein will cross over. This is the same level. We'll have the renal vessels, L1, L2, and remember you'll have your gonadal vessels, very similar level. And then lower down we'll have the IMA, and then our branches for the common iliac arteries. This is from Radiopedia, and here is a MRA image showing the anatomy very nicely. So, vessels of the abdomen, know the variants. So we did a great TikTok of this. This is especially important for IR when you have a replaced left and right hepatic artery. I'll refer you to that. We also go over the IVC duplications and interruptions. It's important if you're ever putting an IVC filter in, maybe you have to put 2 in. And then the left renal vein, we said it should go between the aorta and SMA, but sometimes it goes behind, sometimes it goes in front and behind. So if you know that aorta SMA relationship, you know what vessels, what organs are around there, you are doing quite well. So that brings us to the retroperitoneum. So we talked about the lesser sac between the stomach and the pancreas. So we have our peritoneum here, but then we're going to have the retroperitoneum, and we have 3 spaces. We have the anterior perirenal space, which will include the pancreas, portions of the duodenum, and the ascending descending colon. We will have the perirenal space, which will include the kidneys and the adrenal glands. And then we will have the posterior perirenal space, which is a potential area for fat. Sometimes this is where liposarcomas develop and can be quite large. So very important, retroperitoneum versus intraperitoneal spaces. And for the retroperitoneum, know the anterior perirenal space, the perirenal space, and the posterior perirenal space. So that brings us to places where you have interfaces between the peritoneum and retroperitoneum, including Morrison's pouch. So this is a TikTok I did based on my favorite TV show, The Pitt. They're always doing fast exams with trauma patients looking for fluid in Morrison's pouch. But first we have to understand a normal anatomy. So here's our right kidney, there's the liver, that's Morrison's space in between. What is in there? Well, there's high signal material. And if you go back to the ultrasound podcast, the 3 things that are bright on ultrasound are fat, calcium, and air. Is this calcium? Well, we have our truth machine here. It's dark. It's negative 100 Hounsfield units. This is normal fat. That's what we have around the kidney. In the kidney, the renal sinus fat is fat. So that's normal to have this bright stripe in Morrison's pouch. Let's compare it And here's a coronal view, just showing the liver and the kidney and then the fat there. That's normal. This is abnormal. Here's our right kidney, there's the liver, and we have dark stuff, dark material, which is anechoic. And if you remember from the ultrasound talk, this is fluid. Here's the CT correlation, 0 Hounsfield units. Patient has a huge spleen and a nodular liver. This is cirrhosis with portal hypertension, causing the ascites in Morrison's pouch.
I lost a radial pulse from a broken leg. What did we miss? I don't know. Heart attack, another injury from a car crash? Yes, your pulse system has an fast mode. Diagnosis made. Lemon Morrison's liver laceration.
Thanks for listening to the Don't Miss That Radiology podcast. I'm Dr. Matthew Hartman. Remember, you only see what you know. Keep learning and don't miss that.